for giving us the opportunity to do this demonstration. I would like to thank you all for joining me in this conference room to give you all about live dates and every aspect of DSHub. And I would also like to thank my team here who joined me in this conference. So thank you very much. My name is Muhammad Adam Shamsudeen, and I am the founder and CEO of DSHub, DSHub Innovations Limited. What is DSHub? So DSHub is actually a research and development organization. At DSHub, what we do is specifically we assess academic research-based work and transform them into impactful real-world solutions that address societal problems. And we have been doing this over the years, and we have been deploying mobile solutions for use. And all the solutions were backed by academic research work, because we want to be a pioneer in actually taking research and academic research work into what a real-world solution. So that's what DSHub is all about. And what is our mission? Like I said, DSHub mission is to facilitate the development of intelligent solutions. That's AI, artificial intelligence solutions that will actually improve healthcare and education. This is where we are giving much more focus. And our vision actually is to have an environment whereby there will be access to quality healthcare facilities, whereby each and every person will have equitable access to quality healthcare. So we have LiveGate. LiveGate is actually a product of DSHub. And what LiveGate is all about, LiveGate is a precision healthcare solution. What I mean by precision healthcare solution, LiveGate is a personalized healthcare solution, meaning LiveGate gives clinicians and medical doctors to monitor their patients efficiently, effectively, and instantly. And there are three key terms that define LiveGate, which is detection, avoidance, and recommendation. Let me start with detection. LiveGate, like I said, LiveGate is an intelligent platform that gives doctors first to detect early signs of a medical problem and respond instantly. Then the second one, which is avoidance. LiveGate uses artificial intelligence to actually help clinicians to avoid treatments that may harm patients. That's human errors. And also, the third one is a recommendation. LiveGate uses artificial intelligence again to help doctors to suggest treatment protocol, accurate treatment protocol to medical doctors or clinicians to actually help in decision making. Each and every recommendation made by an AI would have to be approved or rejected by a physician or medical staff, for instance, a medical doctor, just to keep patients safe, because we can never always trust what AI will say. So that's why we have a medical doctor who will always be being the moderator. And the reason why we are using artificial intelligence is because it's a machine, it's a technology, it's much faster. Imagine you are in an environment whereby an ICU, we know how ICU has been. It's quite a busy environment, and an environment that is very sensitive. And there is a lot of flow of information in the ICU. And some of this information might be fragmented. They are all over the place. So we are building a system to streamline any activity that is happening in the ICU. Every single activity, we are streamlining the process in one single platform using the power of artificial intelligence. So this artificial intelligence will give us a powerful insight that will actually help physicians to actually help make better decisions in the ICU, as well as overriding any recommendation made by an artificial intelligence. And at the end of the day, is to improve patient outcome. So I'm going to go to the first slide. and give you our mission for LiveGate actually is to what? Redefine healthcare. We want to redefine healthcare by what? Using powerful AI insights to empower patients to make timely and accurate decisions, ensuring what? Access to life-saving interventions. So everything is happening in an instant, much faster. And our vision, like I said earlier, is to what? Provide equitable access to quality healthcare for everybody. So our research-based team, we are a research and development organization. Everything we do based on academic research work. If it's not valid in academic, we don't take that as any alternative to what providing a solution. So that's why we are still backed by an academic paper. LiveGate is backed by an academic research paper published by an MIT, an author from MIT, as well as Google, a staff from Microsoft. So definitely, our research-based team have assessed some problems that exist in the ICU, and what you are looking at are some of these problems exist in the ICU, which LiveGate is looking at solving. Number one is what? Delay of detection of critical states. Sometimes in the ICU or in emergency units, wherever there is a need for a system like this, some of the system might malfunction, or some of these systems, what I mean by system are medical machines, those sensors and other devices. They might fail to work properly, or they might have some issues, or there might be a delay in what in working with this system. So they might be able to fail to detect, to have early sign of medical problem, detection of medical problem. So, and what you understand is that a small change in a patient medical condition may lead to a deteriorating condition. So what LiveGate is here is going to do is actually to help clinicians early detect sign of a medical problem much early, so that they can avoid them before they happen. That was one problem. And the second one is the data fragmentation. I mentioned about data fragmentation. Some of ICU's data, we actually use data, most especially hardware forms and other data that relate to patients. So some of this data is not well organized. Some of this data we don't really manage them well in a way that we can be able to understand how we can use this information to help make better decisions. So we want to solve the problem of data fragmentation in the ICU. That is why LiveGate is a one central platform where everything that is happening in the ICU is streamlined in one single platform, whereby you can have access to all information all at once and in much more presentable way that you can be able to use and make better decisions to improve patient condition. And the third one is limited data for clinicians. There is limited data for clinicians as well. So due to some limited data for clinicians, they might be able to it may not help them to make much better decisions as well, because they don't have enough data to make some decisions. All I'm talking about data, it can be their own experience, and of course I know that medical doctors also do their own research as well. So imagine having an AI that you interact with immediately, and that AI already knows everything about your patient, because the patient is on the platform. AI knows about the patient condition, AI knows about the past medical history of the patient, AI knows about what you should take next, what actions you should take next. So it's all about you approving what AI says or rejecting, because you are someone with experience that knows everything that should be done on that patient. What we are using AI for is to actually help you to work much faster and efficiently as well. So then I mentioned about earlier about avoidance, which is human errors, or we can call it over-optimistic decisions. There is human errors in work in the ICU as well. Of course, it exists everywhere. There is over-optimistic. Over-optimistic means you make a decision, you make a treatment decision, but that treatment decision you made it because you are in a haste. Maybe you have been overwhelmed. You are in a limited resource constrained ICU, whereby there is not enough facilities or items that you can use to help make better decisions or treat the patient. So because of that, and the patient is in a critical condition, you want to make decision much faster. But the decision you are making is actually a good treatment decision, but there is a risk to that decision. It might cause there might be a side effect, probably maybe. So anything that you can do that may cause side effects or something that you have not really thought much about. So this will also be a problem to the patient actually. So that's why the AI we have on the system will actually help you to avoid over optimistic decision or making human errors as well. So this is human error avoidance. These are the problems we are actually looking at solving for like this. So why are we doing this? You can see we are the right team actually to do this because of these issues that are going in the ICU that are not much addressed in a way that matters. So, and we have a team of experts. When I say team of experts, we are a research and development organization. We have a pool team of workforce and experts that actually deliver this. This is not just one. This is just one product. We are also building other products in another sector. That's why I'm saying we have a pool of workforce that will actually deliver this thing. And this project, the time we set for this project is actually end of this month. That's when we will start testing, and that's the reason why we are here to have this presentation. So basically, the solution we are providing a single, one central solution, one central patient monitoring application powered by artificial intelligence and a human moderator who happens to be a medical physician. Anything happening can be override by the medical physician to keep patient safe. We are not putting patient on artificial intelligence hand. No, you are there monitoring what is happening, and definitely you are going to improve your work efficiently, effectively, and instantly, much more faster. So I will later in this presentation, I'm going to show you a demonstration of the web application. Alright, this is a video, a just short video. This is a video of one of our competitors in the United States. Alright, so what they have is actually one step behind of what we have, what we are presenting. We are talking about AI here. That's because our solution is is powered by artificial intelligence. What they have, they don't have AI. What they have is the patient monitoring web application, and also a way they can improve their clinical decision making. So I want to show you a glimpse of what they have so that you can maybe have a better understanding of the system, because we already have this on the platform of Lafiya, except with the exception of the AI that put them behind us. Alright, let me give you
over the course of a typical shift on the general floor, a single caregiver may be responsible for 5 to 7 patients at once.
Oh, you can tell this.
Or patient care may be delayed or overlooked completely. With a Philips IntelliView Guardian solution on the general floor, a single
avoidance and recommendation, but there is no recommendation here, and that recommendation is done by artificial intelligence, a way that physicians can actually interact with an AI which has been trained with a vast amount of medical data, alright, that has extensive knowledge of suggesting information that physician can be able to use and help and make better decisions, better medical or clinical decision or treatment decision as well. So this is why this IntelliView guidance solution is one step backward, because they have not integrated an AI that will actually provide precision healthcare or personalized healthcare. What they do is the normal way, detecting and responding, more like a reactive measure. something like that. You wait for something to, then you respond, something like that. So that's what that's their solution. So it's more like our solution, but with additional improvements with artificial intelligence. And we are an organization that really focus on building artificial intelligence solutions. So I'm done with this giving you the glimpse. Here is the target users of the live feeds. We are using this two business model, which we call B2B and B2C. B2B is business to business. So with B2B, we are directly engaging with businesses or government institutions. So with these target users, we will be working with tertiary institutions as well as private as well. And this agreement will come based on contracts. Will come based on the contract, maybe yearly contract based on the negotiation. And we are looking to target. This is just a number we put there. So we are looking to start targeting 50 out of these 50 hospitals. We are targeting 50%. That's 25 hospitals because we are a startup. R&D, we want to start with small amounts so that we can be able to be monitoring the numbers, the metrics of the solution. And then we have another users, which we call B2C as well. B2C targets consultants, medical consultants, or any individual who wants to try live-based solution, who wants to interact with our artificial intelligence. Maybe you are a medical consultant. Maybe you are a student, something that maybe you are working on a research paper, or maybe you are doing something as an individual that you may need solution like this to help you better understand how to prepare much better for your career or future. This consultant, we are targeting 100 out of 100. We are targeting just 50%, which is 50 number of medical consultants. We are starting with small amount of number because we want to understand what we are doing. It's not about building a solution. Understanding how it addresses a problem. If you cannot be able to solve the problem you want to solve, then you are building something that you cannot even call a product. You are just wasting your time, actually. So we are really much more concerned on the precision, improving lives of patients, actually. And also lowering, keeping patients at risk. And this is our revenue model. I mentioned about the target audience, B2B and B2C, right? And these are the revenue model. And the revenue model you see pilot, slate, and goal is for the B2C, business to consumers. That's the medical consultant. While the custom, which is the enterprise model, it can be the solution, but it can be customized in any way you want it to to align well with your organization. So this is the enterprise model, which is the custom, and it's based on agreements, negotiations, actually. So there is no cost to it, but when it's more like a contract negotiation agreements. So definitely, if ABU, for instance, is going to be part of the audience, for instance, it will have to be enterprise, but it's up to them. We also have other options for pilot slate and goal as well. And we have projected revenue already because anything that we are doing, we calculate what we do. So imagine this calculation is based on the B2C target consumers. So imagine we have 100 consumers, medical consultants. 1,000 medical consultants subscribe to this to Gold. They have subscribed to Gold, right? So if you times 1,009.99, it will give times 12. It will actually give you 119,000 because we use dollars. So give you the $119,000 in a year. That's 180 million naira in a year. Then in the second year, if you add what you have in the first year, at the growth rate of 20% and a decline rate of 5%, you get $257,000, which is 388 million naira. So if you are an investor you can actually look at these numbers and decide to invest in the life-based solution as well, because we have been presenting this to a lot of organizations and investors as well, because this is something very, very much big that a lot of people, stakeholders, have to be involved in. So this is our competitive advantage table. As you can see, we have identified our competitors already. We know our competitors. You can see Live first, which is our product. You can see Philips Interview. The video I showed you, if you can remember, that's Philips Interview. If you look at these attributes, we have ICU patient management system, right? If you look at this map, Ligate have ICU PMS. Philips have ICU PMS as well. Google Palm 2, they don't have it. IBM Watson, they don't have it. DeepSeek, maybe you have heard of DeepSeek just recently. It's an AI model. It doesn't have it. Real-time monitoring, of course, we have it in Ligate. Our real-time monitoring will be working with the ICU machines in real time. Every information will be taken in real time. Alright, and processed. Philips Intelligence, of course, they have it. Rest, they don't have it. Customization, we provide a way that you can customize Ligate the way you want it, based on your own requirements, and it's our team that will do it. We provide that service, customization, maintenance, anything that has to do with what, including what, Ligate solution actually. We can give you that. So we have the Philips Intelligence, they don't have it. They give us the one step ahead of them. Patient safety. Of course, I've been mentioning about patient safety because I'm an AI professional. I cannot say myself an expert, but I'm an AI professional. I have the background in artificial intelligence. Of course, I care much about patient safety and AI ethics as well. So, patient safety, of course, Ligate 100%. Philips Intelligence, of course, they have that. Then Google, no, because it is not built for actually, these are just large language AI, these are just AI, generic AI, just specifically for what I see. That's why they don't have those features. Low cost, Ligate is much more affordable and it's a local-based solution. The solution from a Nigerian company. So we have a very low cost for what? Low cost price for Ligate, whether it is contract negotiation or what? Normal subscription model. DeepSeek also has a low cost, but still much more expensive than Ligate. But DeepSeek is also low cost. But if you look at other variables, DeepSeek is way behind of Ligate because it's not specific for ICU and it's not made to monitor patient in real time, etc. AI copilots. I mentioned about AI. You can interact with artificial intelligence to help you what? It's like you are engaging with someone who is above you, who have more better knowledge, better expertise and experience in medical field. You are interacting with him, like you are communicating with your own medical doctor, like a friend or someone like that. But the thing is that any information received from AI, you have to approve or reject, just to keep patient safe. Because we build AI, but we still cannot trust it to work 100%. So it will have to be monitored. Yes. So that's why we said for AI Copilot, we have it. Philips Interview, they don't have it. Google Palm, of course, they have AI chatbot. IBM Watson, they have AI chatbots. DeepSeek, they have it. But if you look at other parameters, they are way behind. So that's why this is what puts our Ligate ahead of all our competitors in every aspect. And this is our preliminary agreement and milestone. Our main, it's actually three, include Lagos State Teaching Hospital and also National NH Abuja as well. But we are still in the process as well. But we expect to start with 5 institutions. We want to test this Ligate solution in all these 5 institutions. Already, we have gotten response from UK Teaching Hospital already. Here also we have gotten response. That's why we are having this presentation. NH Abuja called us. We have not yet gone for the demonstration yet, but we are targeting 5 institutions as well, all over. And what we are looking at, what we need from these 5 institutions actually is to what? Have access to their ICU facilities. To what? Help improve, refine our live-based solution, because our live-based solution has been what? Tested on what we have now. We have not tested it with your own ICU machines. So we need to actually access your ICU machines and refine live-based so that it can be able to work much better. And then this is our progress plan. If you look at our progress, we have started with research and building the prototype from January this year up to March. And from March, we are building what? Minimum viable product. Minimum viable product is a product that is ready for use. Like it's ready for use officially. We are now what in the testing stage. We are here, right? Yes, somewhere here. So we are not yet reached here. When we reach here, it can what? Be used on the patients that are here by that time. Alright? But what we are doing now is trying to refine and test. And this is my team. As you can see, some of them are here. Me as the CEO is that's Shamsudeen. That's my picture there. And our product manager is Fabrairu, and Aisha Tari, who is our legal advisor, and Ahmad Al-Ladi, who is he's a medical, is our medical advisor, is also a medical doctor. I think he's doing surgery at the Yobe State Teaching Hospital. And we have a Timothy, who is our front-end engineer, and Hamza Saidu, our back-end engineer, Ibrahim, who is our product designer, and Mariam Hamza, who is our data scientist. So if you look at this is the team that are building live gates. These are the teams that are building live gates. We have a diverse team on other projects as well. So that's why I've been mentioning we have pool of workforce. So there is no anything that you will request from us that we cannot actually provide team to actually address and solve. Alright? So that is all about what I have for you for this demonstration. So I'll quickly go and give you a technical demonstration of the live gate solution. First of all, I want to log out so that you can so that I can start from the beginning. All right. Imagine you have visited the website, right? This is your ICU solution. This is the ABUTH ICU. All right. So you need to, if you are assuming I am an ICU manager, right? So what I will do first is to enter my username, which is admin, and my password is also admin for this demonstration. So I will select role. I need to select role. Either am I a clinician or an ICU manager. So I say, assuming I am an ICU manager. Alright. So if I select an ICU manager, this demonstration, I will show you the demonstration for an ICU manager. And then I will log in. I will wait. We have a slow network, but it just needs more to actually. It's not that it is slow. Our solution is not slow. It's the network. It's the network. And this solution can be used on tablets, phone, desktop, laptop. You can use it across your devices. So imagine you are in a hurry and there is a problem in the ICU. You get notification just like what you see in the video immediately on your phone, and you can quickly call somebody to attend, or you go back to attend much more. I'm very sorry, this network is really excuse me. Yes.
Yeah, I have a suggestion. Why must it be on internet? Why can't it be a desktop application so that you access it within the hospital, within that place? Because we are having network issues in this hospital. So what you are saying, it might not work because of the network problem we have.
We are a research and development organization. We are a research and development organization, and our team, they are diverse. They are not in one state actually. We have team members in Lagos, we have in Abuja, we have in Kaduna, we have in Yobe, Maiduguri. So we work remotely. That's why we do this solution online. But it doesn't mean it's going to be online. That's why I say any requirement this institution needs to provide a team of workforce that will do it. That's why we have customization. Remember, I mentioned about customization. So this thing can be customized any way you want it. It can run offline, 100% offline. No one will have any access to your system, anything. it can be run on your server. We have the team that can be able to set that up for you. Thank you so much for raising this issue. Thank you very much. So let me quickly go and just give you I'm so sorry, I've been holding you so much. Let me go ahead. I've logged in as an ICU manager. From this dashboard, you can see the total patient in this ICU are 33. And if I look at here, I have critical state, I have warning state, and I have stable state. All right. So this critical state, it means that I've already gotten an alert. My clinician, anyone that is monitoring this patient, already have received an alert on his phone or on her phone. You are an ICU manager, you are assessing what is happening. So I've seen critical state 1, right? Then warning state is still 1. Then stable state 31. So you have 31 patients are stable. You know that you have 1 warning and 1 critical. So if I want to go to check this number, we have 33 patients. So I want to see all of them. I want to see the list of them. So if I go to this button, here, I click. To give me the list of my patients. You can see. Alright, these are just for testing. Alright. So you can see, you see the critical, right? It's there, the only one. Alright. But if I tap on it, it will give me options below. Can you see go to patient time dashboard? Alright. But remember, I'm an ICU manager. So imagine this patient has not been assigned to a nurse or a doctor, for instance. There is assigned staff from here. You can see. If I click assign staff, for instance, these are my clinicians, my staffs. I can select Abubakar Adamu, who is a hematology, right? Who is from hematology department. A doctor, I can assign him this patient or this test patient. If I assign, it's in process. So that doctor will get a notification that this patient has been assigned to him, that he should quickly report and stabilize the patient, right? So if I, as an ICU, I want to view the patient dashboard. I want to see the patient condition. So if I click this, go to the patient dashboard, it takes me the patient dashboard. This is the patient dashboard. As you can see, maybe you are familiar with, of course you are familiar with, okay? Because we work with medical advisors. So they advise us on how to build the interface so that it will actually suit you, work well with you so that you can understand everything. And simplicity matters. Clarity matters. We put simplicity and clarity above everything we do. That's why we have this interface for you. Alright, so you can see the name of the patient is what? Fake test. And the patient is male, age 24, height, weight, and there is a status that says whether the patient is alive or dead. Yeah, you can see. Yes. So this is a chart for the ECG. Imagine maybe you have picked up an ECG. Exactly. So it will actually appear. The data will appear in the chart. You can go for date, any filter, and that's SpO2. Of course, you have the devices, so they are taking this in real time. You can be monitoring everything in real time. You can be monitoring these vitals in real time, right? And the interesting thing here is that if you go down, the most interesting thing, if you go down, scroll down, this is a whole timeline of the patient. Right from when patient was admitted, this is the timeline. Any activity done on that patient, you can actually go back and review it. Today, this activity was done on the patient, medication. What happened? Let me go and click medication. You can see what happened. There was a medication given to this patient. That's the test patient, right? These are the medication given to him. So imagine it is a nurse giving this information. What? Should what? Do the right thing, right? And you can see the other information there. Administered by what? The doctor who gave the information, the prescription is Abubakar, right down there. And it's still ongoing. It's not completed yet. Maybe the patient has not taken the medication yet, or has not started with the medication. So remember, like I said, this is patient timeline. So imagine, also what I want to say here again is that apart from this medication, imagine you have collected vitals on a patient at 1 o'clock, right? At 1 o'clock. So it will also appear here that you have taken a vital. You can see the vital taken. So imagine we take another one in the evening, maybe around 6. Here, it will also appear here. So you can compare previous vital and what? Current vital that you have collected. So this will actually help you work much more faster because everything is on your screen and the information you access are not ambiguous. There is simplicity in every aspect. That's why if I click, I can go all the way back. I'm leaving today, I'm going to what? This date. Right? 19. When is 19? That's yesterday. You see? Imagine the patient is 2 weeks in the ICU. So I don't know if the patient can take up to 2 weeks in the ICU. Alright. So you can go all the way back to 2 months and compare everything there. Alright? So this is very interesting. These are patient timeline. We call it patient timeline. You can actually see everything there on the patient timeline. Alright. So this is just a simple example of the ICU. There are so many things there, but I don't think we have much time to all do this thing. There is settings. If I go to settings, I can see the what? The total patient in the ICU, like 3, total staff in the ICU, 3. You know, these are the trends of the ICU, and then log. This is the log. Maybe I assign a patient to a clinician. It will show that something happened, an activity happened. So as an ICU, I can monitor everything that is happening in the ICU. I can monitor anything that is happening in the ICU. Because we have combined everything on one platform. We have streamlined the process. Every single information is very, very vital. We don't leave it. We take it to use it to provide what? Insightful resources that will help you to actually make better decisions. It's all about making better decisions. Reducing human errors. Human errors is one of the things that is really, really affecting our work. So we want to reduce human errors because if you have a system like this, even if you are working in an environment that is very, very toxic, or sorry to use the word, that is resource constrained, there are not enough resources. You can still be able to do things here with the help of our artificial intelligence and also with the knowledge we are having with all this data. You know what you are doing, you know what you should expect, you know what action to take. You are not handling manual information from one point to another, from one unit to another. Everything is happening on the device. So that is the IC managers are also I also here, let me show you that you can also, as an IC manager, you can add a staff, you can add a patient, or as an IC manager. So this is a form where you add a staff there.
Patient.
But also you can also import. I know maybe you work with spreadsheet, right? This is also spreadsheet. Yeah. So you can also maybe you have a record of patient on spreadsheet. You can upload it on this app, so that you can just add patient much faster rather than one by one. Okay. From the spreadsheet, when you upload the spreadsheet, just all the patients will appear. So you can have better integration. So this is an IC manager tab. If you click here, you can see add a patient, add a new staff there. Something that I would like to show you. Here you can see manage patients. You can see add patient from file. If you add patient from file, you select spreadsheet, then you upload. Automatically you see all your patients. Yeah. And also you can export all this data inside you are seeing. All this data, the charts and everything, you can download everything. You can export it to spreadsheet and download it. Do you get it? Yeah, everything you can transform it into a spreadsheet and just see it there. You can download it. So that's all I think I have for the IC manager. Let me log out and log in as a clinician. As a clinician. Only meant for the ICU manager, right? An ICU manager is above everybody, so he can see everything. But the clinician, there are some things that the clinician will not be able to see. So anything you see here is the things that the clinician will be able to see. Alright, it's the same process. If you go to the left side of, you can see the patient list here. But because I created a new clinician, no staff has been assigned to this clinician that I created. That's why from here, there is nothing because no patient has been assigned. That's why there is nothing. Recently admitted patient, no recently admitted patient. All the patients that you see were added. Maybe they have been there for 2 weeks already. So no recently admitted. Here are issues with comments. Whether there is patient on need critical intervention, you will see the patient name, condition, and the comments here as well. You as the clinician, you will see. So if it's something, the patient that has been assigned to you, you can be able to respond much faster. So let me just go to the patient list here. And you as a clinician, you can request for discharge. When you request for discharge, it is the ICU manager that will approve it. So from here, you can be able to request for discharge. It's the same thing. You can go to the patient profile and access the patient back here as well. You can see as a clinician, you can review what any activity that has been done on the patient timeline. See what happened today. Go way back. What happened yesterday. You can continue to go back up to when you listen. So the AI integration, the AI co-pilot is not ready yet. Because I said end of this month, that's when it's going to be ready. That's the time we set the AI copilot. So the AI copilot is going to be just around this here. So when you click the button, a chat box will appear where you can interact with the AI. Anything you discuss with the AI will have to be based on this patient because the AI already knows that you are examining this patient, right? So it already knows. The AI knows because the AI is monitoring anything you are doing on live video. Every single thing the AI knows. So once you start interacting with the AI, it will actually cooperate with you and give you the best possible recommendation that you can be able to accept and make better decisions. Unfortunately, the AI is not yet ready to show you how you can be able to communicate with the AI. But as we move on, definitely we are going to give you this demonstration for the AI implementation. So I think that's pretty much it, and I want to thank you all for listening to me right from the beginning. We really appreciate it, and we hope for the best in few months or few weeks to come. Thank you all. Thank you very much. Okay, so there are no any more questions, right?
No. Also, in the channel.
Okay. No problem. I did.
Just very sure. Good morning to you all. Sorry, before me is the agenda of the meeting. So I was before the meeting just about 10 minutes ago. I picked you before while you were making the presentation. Was the SEMA component that another important meeting with the CMP? We directed with ABUTH, SEMA, and to share the meeting on behalf of the SEMA. So before me the agenda, so we have already reached, we have moved to the item 3 on the agenda. But I think we can just formalize it without wasting much of our time. The opening agenda is the agenda before me is opening formalities, remarks, demonstration by the company which we have done, then comments, and contribution which is the authority to AOD and closing formality. So we take 30 seconds to say according to our script. Let's break so we open up. Okay. Okay, chairman's remark. So first I apologize for coming late, though I was informed late. But at the same time, I don't know whether we have done the introduction so far. We introduce the ABUTH team and the ICT team, so I start my comments, my remarks.
Okay, sir.
So,
Yes, sir.
on my, as I initially said, I'm from the Divine DC Martinez. On my right, we have
I am training officer and officer. I'm the previous manager of data analysis. I see.
My name is Sabbin, the position is the Antigua Department.
My name is Ahmed, head of IC. I'm the Pharmacy of Who, I'm the director of IC. Dr. Mohammed. Alright. Yes.
I'm Lafiya, the central, most intensive secretary.
Thank you.
I'm Hawa Marut, the manager in charge of ICT.
Coming back to us here, Mr. Joshua Bennett.
DSHub fasaha.
Yes. And I'm Muhammad Adam Shamsudeen, and I'm the founder and CEO of DSHub.
Yeah, welcome to ABUTH. From the data sent to the hospital and other correspondences, I stored data and from 16th of January to 20th of January. The patient monitoring application in our hospital. So I saw all the masks that have gone around in the HOD, DA, ICT, and everybody are okay with proposal, and that is why the hospital communicated to me. It's a very important software. As you all know that this is the education hospital is a tertiary center in the country, and we are already transforming from analog to digital. Right now we have our EMR, electronic medical records, and also electronic health records. So already from DSHub, I know there are I think units for taking care of ward and I don't know of ICU. So whatever the case, I think we can integrate this very important software with our existing software so that we can add value to our services. And from whatever something is brought in the hospital, we always consult with end users, and the end users are very happy to patronize and institutionalize your own software. So without wasting much of our time, I think we have made the presentation. I think we can start from there. You have finished the presentation, then the patient has to comment on further observations. As for the hospital is willing and happy to accept you, to accept your company, and also to see if your software they are going to develop, how we can add value to our system and improve our quality healthcare services. Welcome to ABUTH, and we hope that this session will be a very important one and will help us to execute our plan. Thank you very much.
Thank you very much.
Demonstration of the software by the company which has already been done. So we move to the item number 4. That is observation, comments, and control. Thank you very much.
Just as I said, I can see your education is your PhD. You have to connect the internet before you access. And why don't a suggestion? Why don't make it your next stop needs application to use and because we are having a lot of network issues. If you say we leave it as what days we have network issues and I can see that there is problem. And I can also that I would strongly suggest desktop based application. If a doctor or any physician want to use the AI you're talking about, maybe next year, but as for the application, you
Thank you very much. Thank you very much.
of the DSHub?
So from us, the end users, we'd like to know what grade of equipment is compatible with this software. Okay. Yes, the physical infrastructure you need.
So the requirement specification of the system.
Yes, the monitors that can work with this, you know, so that by the time you build your software, you're able to work with our monitors. Right now, we have a central monitor that has not been working for quite some time. We have been finding it very difficult to activate it because the people that installed it refuse to come and open it when you use that much. Yeah.
And you know this, so
Yes, so
this all the
this,
information from there.
yeah, you can install a new computer and connect it.
Yes.
Yes, with the way they are, at least the minimum can get from this, the minimum of the central monitoring. Yes. So we are happy with it. Now, the co-pilot, you have not piloted it anywhere for now? This. No, not yet. Okay. So, we can't be talking about the data safety, especially when you are using the internet. You know, safety of patient data is a major issue now in the age of AI okay, so that has to be taken into consideration. Now, I saw that you showed ECG. So, apart from ECG, can you monitor everything that the machine monitors? The monitor, apart from ECG, that you have customized ECG, SPO2, beyond that, like capnography, like entropy, you know, those are things that we actually like ABUTH, all those things, so that a variety of things you monitor that estimations higher than what you captured. Okay? Now, if you have faulty equipment, which you are in Nigeria, it's a common occurrence. You know, one of the monitors on the patient may not be working. When you borrow from one patient and and use on the other patient. So there must be an avenue to take note of those things in the system can.
The central monitor should be able to address that. When you see, central monitor should all the parameters.
No, but I think central monitor is specific monitor. And you borrow the machine, which you use on
I think when you have a central monitor, it's supposed to take the monitor from the patient. If you remove the patient's doesn't there, it will see the test.
But you record it against the bed. The original bed monitor. Yeah. So it's for different patients. Now,
the data, the parameters are not specified for the patient. If I were then enter on bed 4 and remove the sensor and which is for 3, it will show it only should enter for bed 3. It's not specific for bed 4. If I move it,
but the central monitor, and what central record, we record it against
and that's it.
So when you come to do retrospective analysis, instead of seeing what you did for bed 4, you drag
for that specific time. For that specific time, maybe it's 3 o'clock. You will not see anything capnography on bed 4 because it's not been recorded. Simple, isn't it? You understand what I mean?
You not see on the original,
you will not see on that chart.
On the faulty bed that you borrowed.
Yes, you will not see.
Okay. Now, what the logging is very important. This is a teaching hospital where you have multiple clinicians attending to the same patient at a time. So if you assign that patient to one person, how can the other team members, make assessment or addition or some, access that patient better? Or age,
incident
or profile, then, because, yes. Like remaining, when you added a new clinician, you didn't see that alone she was a female nurse. You didn't see anybody. And there were already 31 patients on admission. 33 patients on admission. So ideally, as you add a new staff, you need to see everybody in the ICU. That's what makes sense. When you tell our parents we are assigned patients to staff, you know, it's understandable. But here, you don't assign to a single staff, you assign to everybody. It's a teamwork that we do in.
I don't say for radiological.
Yes.
Or my lab.
Yes. Even in the lab, the hematology guy you call, come as a team.
Yes.
But you don't even assign patients. What you do, if they open to your page where the patients are, anybody, if I have a password, I'll go to the patient, click and whatever I want to do.
That's like
Yes.
Prof will come now and do the same. The ACT is going to work and everything. Any of us, but you don't assign a specific.
Now, also, in the admin, like in the ICU, you have admin on the nurse's side, you also have admin on the doctor's side. So, you are going to have multiple admins. That's another, you know, thing that will bring
admin, she going to be principal admin.
Yes, because she assigned the nurses to their duties. The doctor has no business with the nurses' rotation, as they do their job.
So the admin will be a doctor admin.
Now, that's how we see teaching hospital, there are cadres of staff, and each line of management is on hierarchy. You know, like there are technicians, they are separate from the technicians, and they also work almost daily in the ICU. You know, so all this, you know, because it's teaching hospital, it's not as simple as it is. The AI component, I don't know. AI you must use internet, right? For AI. So as it was, I think I buy the idea. If you want to go AI, you go log in.
For the AI part, of course, we can do it locally. We can host a local model.
Oh, beautiful. So that would be the best for us, because we are in Nigeria. Right. Those are my observations.
All right, thank you very much.
And also, what manager I feel since you are commanding this patient, you're able to have access to both treatment and the guidance of the patient. Both the nurse and the doctor are supposed to have access to that.
Thank you very much. I wish that our medical team are here because of our workforce are diverse.
Yeah.
They are across the Nigerian state.
They
Most of them are from the northeast. So
they understand what we're working most of them.
Definitely very soon we will be bringing them as we move forward.
Actually, it's not a new feature. It's just that it's now with AI. We're doing central online, offline. We're doing the introduction to HR, right? Good for those things. Admitting patients, adding procedures, adding logs. So this I think we have to learn. And I think there's not much difference. Right? Not much difference. So much difference. Just the AI component.
And the central monitoring.
And the central monitoring.
Yes, very important. The minimum we can get from this is that central minimum.
They have to go and check what we have.
Yes, we need to assess our infrastructure and see how,
as you are developing
Yes.
towards the end of the month.
If possible, managing the equipment.
don't worry, that is management.
People that get that one, I think it's working. It's not a block.
And let us see.
I don't know. Do you have anybody from your side that is taking the observation?
Yes, yes,
Yes, just recording.
Yes, yeah.
Yes, I think very important observations because I think the presentation I noticed is more of a private setting with minimum patients and maybe 1 to 2 persons. In teaching hospital, we have different things. The main person that observes the patient of the after being discharged and surgeon anesthetic. Okay. More physician. So at the same time, he has his nurses, technician, attendant, and others. At the same time, in the course of treatment, the patient may also want another physician may be invited, or they may invite another technical person to come and let him. So what we used to do, the analog one is the file, just come and write your note observations and continue the management as it is. So whoever comes, you will look at what is done to that patient and some time on the day, then you will start. But in this case, when we are dealing with software, different aspects, different managers in mind, but we have the same person. Because all we are doing here is verification. Multiple people have access to the same person, and at the same time making their image for the betterment of society. So I think I'm happy to hear that we have to see how we now we already have our electronic health record. So the modification we do and other upgrades that your software has will be very welcome, and at the same time we need to improve our service. So these are some of the things that I have to take now as a message to go to the final product. Because it's a presentation to see what new things we have to do to us to internalize it for the betterment of our service. So these are some of the considerations I think we can look at it and modify. And it also sends a market. If you are successful in knowledge, I'm telling you so many hospitals definitely will work. Because from the interaction, I think I've got to got many competition between hospitals in Nigeria. So this will be a non-rating, like a pilot, exactly like a pilot study center where we can improve our strategy and send it over there. I encourage your confidence and initiative. But it's a home-based, local innovation, which we are always happy and we are very proud of. We encourage you guys to do wonderful. Yeah, absolutely. Where did you play?
Where did I
Play.
Okay, I did my BSc Information Technology in Malaysia.
Okay.
I did MSc in Computer Science in Ahmadu Bello University, Lafiya. I did an MBA here in Ahmadu Bello University, and that's pretty much.
Because this innovation literally either Asia or India.
Sabbin University.
Yeah, Damansara.
Okay, which school? Inti. One state.
Inti. You get some black.
Okay.
Science college back.
Bana wuce da Mansara. Kana taba zuwa Cyber Jaya.
Oh, Cyber. Instead of Cyber.
Okay.
You have to read it. So thank you very much. Any observation again? So what's our next step now? Item number 4, observation from the contribution session.
Anything you want to add?
Anything you want to add from our interaction? The team members, you allow me to speak for you.
That's key thing, main objective, our main objective after this meeting. We want to have access to these facilities, access all the devices, all the machines with our technical team, so that, including our medical team as well, so that we can be able to understand how we can proceed and integrate these your devices with live bits. Yes. And also, and also we want to still this partnership. We want it to be a long-term partnership, whereby we will continue to test and deploy solutions like this, because we are a research and development organization. We don't just work on one product. What we are doing is to try to be a pioneer in pushing the development of intelligent solutions that will address diverse problems in this country. In this country, we lack organization of research and development. They are very limited in this country. Some of them exist, but they don't function. So we want to actually be part of this this journey in actually driving the creation of solutions. And I think even the government, this is what they want to see in Nigeria.
Any other things?
I think we should have a talk with our ICT people.
So it's okay, so no problem. I think
Sir, sorry sir. I hope you should not be a situation where you start listening with study and if problem happens, you'll be invited to come and correct and you will not see.
That's a big problem.
So I forgot to mention one thing. We are actually going to train your staff as well. Apart from integrating this solution, apart from all that, we want to train your staff on how to work with this system, even including maintenance. In case we might not be available in some, but we will always be available because our office is in Kaduna, Manali. That is our office. So we will always be around.
Okay. So I think in the absence of any other business, I will talk now as part of the management team. Thank you for coming to ABUTH and for the presentation. From the discussion, I will use the power of CMD to give you the permission to access our tools to see how you can integrate that in. Then secondly, as a tradition in the hospital, whenever we have something new, the company will write an MOU, we give our legal unit to go through before we sign, then we see the deal before we start it. But for now, we have some observation which you have to take into consideration, incorporate and develop your software, then at the same time, then the final stage is when we are going to assess it for having satisfied our requirements and specifications. And then from there, the MOU will come, then even the price and this, what you call it, the issue of continuous thing. And what we call maintenance, okay, maintenance and other financial implications. Because I know it's not a title organization. I know that is very free. Then from there, the issue of
even talking about investment, it's not you're not the way you show it. Okay, I go to 1 year, I was going to invest in Nigeria, converting dollars and all that. How would
I need those.
We have a pool of 10% of our share. So anyone that wants to invest actually can come in and invest. We have 10% of our share.
even the hospital can invest.
Oh, I need those.
Anyone was right at the beginning.
So it's okay, that's a good one. And this actually is the of the presentation. But for the time being, actually you are permitted to go through, see our targets, then expand the software. From there, when we are, maybe we need to do a certain presentation. When goes our specifications and needs are captured, well, then from there, we can estimate. Then,
All right.
thank you very much. I really appreciate it.
Sir, I wanted to appreciate the move by the management. Looking at the state of our ICU, but this is giving me hope that our ICU is going to be revived. So this presentation is very welcome, and I pray that the management will really put hearts together with them to see that something come up in the ICU. Thank you very much.
Thank you.
So I think lastly, closing formalities, we are starting with prayers. Let's pray and go to be very welcome, and at the same time we use it to improve our services. So these are some of the things that I have to take it now as a message to the CMD, because it's the final board. It's a presentation to see what new things you have to deploy to us to internalize it for the betterment of our services. So these are some of the observations I think we can look at it and modify. And it will also sell your market. If you are successful in ABUTH, I'm telling you, so many hospitals will definitely invite you. Because from the interaction, I think I have not deployed to any of the teaching hospitals in Nigeria. So this would be a groundbreaking, exactly like a pilot study center where you can improve your services and sell it to others. I encourage your confidence and your initiative, because it's a home-based